Hello everyone, welcome back to Conquer Pathology with Dr. P. Today we aren't just studying a chapter, we are studying the emperor of all maladies. Neoplasia is the ultimate challenge in medicine. It's where our own cells turn against us. This chapter is the heart of systemic pathology. If you understand neoplasia, you understand how the body breaks its own rules. By the end of this lecture, you won't just know the definitions, you'll understand the molecular why behind every cancer you see in the wards. We'll be following the NMC CBME Competencies strictly, integrating clinical medicine, surgery, and pharmacology. So you are not just passing exams but becoming a great clinician. Grab your Robbins, your colored pens, and let's dive in. Part 1. Introduction. What is neoplasia? Sir Rupert Willis said it best, and you must know this. A neoplasm is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of the normal tissue and persists in the same excessive manner after cessation of the stimuli which evoke the change.
I'll leave it for Dr. P to simplify this definition. Toodles!
Thank you, Sir Rupert Willis. Think of a normal cell like a disciplined soldier. Neoplasia is like a soldier who goes rogue, stops listening to the captain, starts multiplying uncontrollably, and even recruits others to join his rebellion. Part 2. The anatomy of a tumor. Every tumor has two departments. The parenchyma, these are the actual neoplastic cells. They determine how the tumor behaves and what it's called. The stroma. It is the supporting cast. This includes connective tissue, blood vessels, and inflammatory cells. Desmoplasia. Some tumors, like breast cancer, stimulate the stroma to produce massive amounts of collagen. This makes the tumor stony hard or serous. Part 3. Nomenclature, the name game. How do we name these growths? It's all about the suffix. Let's first take benign tumors, the polite ones. They usually end in oma. Mesenchymal benign tumors. The fibrous tumors are fibroma, bone tumors are osteoma, and fat tumors are lipoma. Epithelial benign tumors. Adenoma forms glands, papilloma forms finger-like projections, and cystadenoma are hollow cystic masses common in ovaries. Malignant tumors, the aggressors. Malignant tumors arising from epithelial tissue are named carcinoma. They come from ectoderm or endoderm. They spread via lymphatics usually. For example, squamous cell carcinoma, adenocarcinoma. Sarcoma. They are the malignant tumors arising from mesenchymal tissue. For example, mesoderm, bone, muscle, fat. They spread via blood usually. Example, osteosarcoma, liposarcoma. This is the naming rule book or the OMA logic. The benign tumor of squamous epithelium is squamous papilloma, whereas its malignant counterpart is squamous cell carcinoma. Benign of glandular epithelium is adenoma, whereas its malignant counterpart is adenocarcinoma. So on and so forth for fibrous tissue, that is fibroma and fibrosarcoma, cartilage, that is chondroma and chondrosarcoma, and blood vessels, hemangioma and angiosarcoma. Now let's see about the liar omas. Not everything ending in oma is benign. You can learn this with the mnemonic. Melanoma can help lymphomas and seminomas. Here, melanoma, hepatoma, lymphoma, and seminoma all are malignant. Now let me give you my neoplasia mantra. There are no benign tumors in blood. That is, all tumors of blood are malignant. Now let's see some tumors that operate beyond basic nomenclature. Mixed tumors. For example, pleomorphic adenoma. It is a mixture of epithelial plus myoepithelial cells with chondroid stroma. Teratomas. These arrive from totipotent cells from at least 2, usually 3 germ layers. Dr. P's pearl. We distinguish between mature teratoma, which is the benign one, and the immature teratoma, the malignant one, based on the presence of neuroepithelium. Blastomas. These tumors resemble embryonic tissue, for example, retinoblastoma, nephroblastoma, or Wilms tumor. Don't get confused by these pseudotumors. Hamartoma, a disorganized mass of native tissue in its native site. For example, a lung hamartoma with cartilage and bronchial tissue. It's benign but looks scary on an X-ray. Choristoma. Normal tissue in an abnormal location. For example, a small nest of pancreatic tissue in the stomach wall. Think of it as a tissue traveler. Part 4. Benign versus malignant, the great divide. This is a favorite Viva and university question. Let's break it down into a table. Benign is well differentiated, looks like the parent tissue. Malignant ranges from well differentiated to anaplastic or undifferentiated. The rate of growth of benign tumors is slow, whereas that of malignant tumor is rapid. Local invasion. Benign tumor is cohesive and has a capsule, whereas malignant tumor is invasive and infiltrates surrounding tissue. Metastasis is absent in benign tumors, whereas it is present in malignant tumors. The metastasis is the hallmark of malignancy. Let's take a deep dive. Differentiation and anaplasia. If the tumor is well differentiated, you can tell this is a thyroid cell, so it is a benign or low grade tumor. Anaplastic, I have no idea what this is. It could be high grade malignancy. The key concept here is anaplasia. Anaplasia means to form backward. It is a hallmark of malignancy. Look for pleomorphism, cells of different shapes and sizes. Hyperchromatic nuclei, dark and large nuclei. There is high NC ratio. Normally, the NC ratio is 1:4, but in malignant tumors, it is 1:1. Mitotic figures. Lots of tripolar or quadrupolar mitosis. It looks like a Mercedes sign. Metaplasia versus dysplasia. In metaplasia, one adult cell type replaces another, for example in Barrett's esophagus. It's reversible. But in dysplasia, there is disordered growth, loss of architectural orientation, and if it involves the full thickness of the epithelium but doesn't cross the basement membrane, we call it carcinoma in situ. Next point is rate of growth. Usually, growth rate is proportional to the level of differentiation. If it is fast growth, that means more mitosis will be there. This is why chemotherapy works better on fast-growing tumors like leukemias than slow-growing tumors like certain sarcomas. Local invasion. Benign tumors grow by expansion and usually have a fibrous capsule, the safety wall. Malignant tumors grow by infiltration and destruction. They don't respect boundaries. Last but not the least, the metastasis, the deal breaker. If the tumor metastasizes, it is malignant, except for CNS gliomas and basal cell carcinomas of the skin, which are locally malignant but rarely spread. We'll see metastasis in great detail later on in this lecture. Part 5. Carcinogenesis and etiology. Let's look at the causative factors of cancers. First one is chemical carcinogens. Directly acting chemical carcinogens don't need any modification, for example some chemo drugs, whereas indirectly acting or procarcinogens need metabolism in the liver via cytochrome P450 pathway. Aflatoxin B1 causes a specific mutation in P53, causing arginine to turn into serine, which causes hepatocellular carcinoma. Next one is radiation. UV rays form pyrimidine dimers. If the nucleotide excision repair system fails, you get xeroderma pigmentosum. Ionizing radiations like X-rays or atomic bomb. They cause papillary thyroid carcinoma and leukemia. Viral and microbial carcinogens. Following is the list of viruses that cause certain cancers and the mechanism through which they cause that cancer. HPV 16 and 18 cause cervical cancer and oropharyngeal cancer. E6 inhibits P53 and E7 inhibits RB gene. EBV virus. It causes Burkitt lymphoma. Translocation 814, that is translocation of MYC gene takes place. HBV or HCV cause liver cancer. The mechanism is it causes cancer through chronic inflammation and regeneration. HTLV1 causes T-cell leukemia. The TEX protein activates the growth. Now let's discuss the environmental factors causing cancers. Dietary factors like high fat and low fiber diet cause colon cancer. Smoking causes lung, bladder and pancreatic cancers. Alcohol causes oropharyngeal, liver and breast cancers. Age and genetics. Most cancer occur in the 55 to 75 age bracket. Why is that so? Because mutations accumulate like dust on a shelf. Some are inherited cancer syndromes. RB gene inheritance causes retinoblastoma. APC gene causes familial adenomatous polyposis. 100% of these patients get colon cancer by age of 40 if the colon isn't removed. Part 6. The hallmarks of cancer, or we can call it the molecular basis of cancer. This is the core of Robbins. Let's use the Rogue City analogy. Hallmark 1. Self-sufficiency in growth signals, the stuck accelerator. Proto-oncogenes are the accelerator. These are normal genes that promote growth. When mutated, they become oncogenes, for example RAS. It is the most common mutated gene in humans. Let's look at its story. Normally, RAS waits for a signal to tell the cell to divide. Mutated RAS is like a doorbell that keeps ringing even when no one is pushing the button. Let's integrate this with biochemistry. This involves GTP binding. Mutated RAS can't hydrolyze GTP to GDP, so it stays on. Chromothripsis, the chromosome shattering. It's a relatively new concept where a single catastrophic event causes a chromosome to shatter and stitch back together incorrectly. This can activate multiple oncogenes simultaneously. Hallmark 2. Insensitivity to anti-growth signals, the broken brakes. Tumor suppressor genes, these are the brakes. These stop the cell cycle. For example, the RP gene, it is the gatekeeper of G1 to S transition in your cell cycle and the governor of that cell cycle. If both copies are lost, you get retinoblastoma. Let's look at this interesting concept of the two-hit hypothesis given by Knudsen. You need 2 hits or mutations to disable the brake. Sporadic. Both hits happen after birth. One eye is affected. Familial. You are born with one hit and the second hit happens later. Both eyes are affected. Next example is the guardian or TP53 gene. If DNA is damaged, P53 steps in. It induces P21, a CDK inhibitor, to pause the cell cycle. If repair fails, it tells Bax, the executioner, to kill the cell via apoptosis. In more than 50% of human cancers, P53 is deleted. The cell forgets how to die. Let's integrate this with genetics. Li-Fraumeni syndrome occurs when you are born with a mutated TP53. Hallmark 3. Altered cell metabolism, the Warburg effect. Normal cells use oxygen to make lots of ATP through oxidative phosphorylation, whereas cancer cells use aerobic glycolysis. They turn glucose into lactose even with oxygen. Why? Because glycolysis provides metabolic intermediates like lipids, amino acids to build new daughter cells. This is the basis of PET scans using fluorodeoxyglucose. This hunger for glucose is how PET scans work. We inject radio-labeled glucose, and because tumors are using the Warburg effect, they suck up that glucose brighter than normal tissue. Hallmark 4. Evasion of apoptosis. Tumors upregulate BCL2, the anti-death protein. Let's integrate this with pharmacology. Venetoclax is a BCL2 inhibitor used in CLL. Hallmark 5. Limitless replicative potential or immortality. Normal cells have clocks called telomeres that shorten every time they divide. This is called the Hay-Flick limit, limiting the number of times a cell can divide. Cancer cells produce telomerase, which keeps the clock running forever. They become immortal. Hallmark 6. Sustained angiogenesis. Tumors cannot grow beyond 1 to 2 mm without blood. They secrete VEGF to induce angiogenesis and the growth of new capillaries to feed themselves. Let's integrate this with oncology. Bevacizumab is a drug that starves the tumor by blocking VEGF. Hallmark 7. Ability to invade and metastasize. The metastatic cascade, the great escape. How does a cell move from the breast to the bone? First step is loosening of cell-to-cell junctions. There is loss of E-cadherin, which is the cellular glue joining the cell to cell. Next, there is degradation of extracellular matrix. The tumor secretes MMPs, matrix metalloproteinases, to chew through the basement membrane. Then, it attaches to new ECM components. Migration. Amoeboid movement through the hole they just chewed. Intravasation is them entering the blood or lymph. The voyage. They travel in clumps with platelets to hide from immune cells. Extravasation and growth. They land in a new organ and grow there. You can memorize the hallmarks of cancer by this mnemonic. Selfish evaders limit destruction, inducing angiogenesis and metastasis. That is, self-sufficiency in growth signals, evading growth suppressors, limitless replication, destruction or evading apoptosis, inducing angiogenesis and metastasis. Now let's look at how the cancers are spread. The lymphatic pathway. It is the first stop for carcinomas. Sentinel node is the first node in the drainage basin. Hematogenous pathway. It is the expressway for sarcomas. Liver and lungs are the most common sites. And then there is seeding in body cavities, for example ovarian cancer spreading all over the peritoneum. Now a question arises, are there any exceptions to this rule? This is the $1,000,000 question in Viva exams. Examiners love to catch you on the always/never trap. While the rule of carcinoma equals to lymphatics and sarcoma equals to hematogenous holds true for about 90% of cases, the exceptions are high yield facts you must have on your fingertips. Let's break these rule breakers down with clinical integration and some cheat code mnemonics. We normally see that carcinomas prefer lymphatic or lymphatogenous pathway. But now we'll look at the exceptions of carcinomas that prefer the expressway or the hematogenous spread. While most epithelial cancers take the slow scenic route through lymph nodes, these 4 aggressive carcinomas dive straight into the veins. The 4 horsemen of hematogenous carcinomas. First one here is renal cell carcinoma. It is a classic example. It has a tendency for venous invasion. It grows as a tumor thrombus into a renal vein and can even reach the inferior vena cava and the right heart. Hepatocellular carcinoma. It invades the portal and hepatic veins early in the disease. Follicular carcinoma of the thyroid. Unlike its cousin papillary carcinoma, which loves lymph nodes, follicular carcinoma spreads via blood to the bones and lungs. Dr. P's pearl. If you see a thyroid mass with distant bone metastasis but no lymphadenopathy, think follicular. Choriocarcinoma. A highly vascular tumor of placental origin that disseminates hematogenously very early, usually to the lungs. Dr. P's mnemonic. 4 horsemen of the bloodstream are renal, hepatic, follicular, chorio. Real heroes fight cancer. Next we'll see the sarcomas that take the side streets or the lymphatic spread. Mesenchymal tumors usually hate lymph nodes. If you find a sarcoma in a lymph node, it's rare and usually points to a specific subset. These scare exceptions. In your exams, if an examiner asks for sarcomas that spread via lymphatics, give them this list. Scare. Synovial sarcoma, clear cell sarcoma, angiosarcoma, especially of the scalp, rhabdomyosarcoma, especially the alveolar subtype, and epithelioid sarcoma. Epithelioid sarcoma is the most common sarcoma to spread to lymph nodes in the upper extremities. Why do these exceptions exist? The basal lamina barrier. Carcinomas are epithelial. To reach the blood, they have to cross a thick basement membrane and find a vessel. Lymphatic capillaries have much thinner, more wholly fenestrated walls, making them easier to enter. Next reason is the vein invasion property. RCC and HCC produce specific proteases that favor the degradation of venous walls rather than lymphatic channels. Let's integrate this with surgery and radiology. For papillary thyroid carcinoma, we do a neck dissection to get the nodes. For follicular thyroid carcinoma, we focus on post-op radioactive iodine to catch the distant blood-borne spread. In RCC, the radiologist must check the IVC. If the tumor reaches the heart, the surgical approach changes from a simple nephrectomy to a major cardiothoracic procedure. So here's the summary table. The rule is carcinoma is spread via lymphatic pathway, whereas sarcoma is spread via hematogenous. The exceptions for carcinoma are RCC, HCC, follicular thyroid carcinoma, and choriocarcinoma. Why it matters? These escape nodes go straight to lungs and bones. Whereas sarcoma exceptions are scare, synovial, clear cell, angio, rhabdo, and epithelioid. Why it matters? Because you must palpate regional lymph nodes in these specific sarcomas. Let's look at a few important concepts. The concept of field cancerization. The definition is the presence of submicroscopic genetically altered cells in a large area of tissue surrounding a tumor. This explains why a surgeon might have clear margins on histopathology, yet the patient develops a second primary tumor in the same area. It is common in head and neck and bladder cancers. Next concept is the epithelial mesenchymal transition or EMT. This is a high yield topic. To migrate, Epithelial cells must lose their identity. The transcription factors involved in it are snail, slug, and twist, and the markers are downregulation of E-cadherin and upregulation of vimentin and smooth muscle actin. Next one is the seed and soil hypothesis. Why does prostate cancer go to bone? Why does bronchogenic carcinoma go to adrenals? It's about chemokine receptors. For example, CXCR4 on tumor cells seeking CXCL12 in the soil. Enough about the theory. Now let's talk about the clinical features of neoplasia. The first one here is cachexia, or the wasting. It's not just the lack of appetite, it's a hypermetabolic state driven by TNF-alpha and interleukin-6. The result is loss of muscle and fat equally, unlike starvation. Next one, and very important one for your theory, is paraneoplastic syndrome. These are symptoms that cannot be explained by the local spread of the tumor. For example, acanthosis nigricans, the dark velvety skin in the axilla. It is seen in gastric cancer. Polycythemia. It is seen in renal cell carcinoma due to production of erythropoietin. Trousseau sign. It is a migratory thrombophlebitis seen in pancreatic cancer. Lambert-Eaton syndrome. The muscle weakness mimicking myasthenia gravis. It is seen in small cell lung cancer. Sometimes the tumor produces hormones it shouldn't. Hypercalcemia. It is the most common paraneoplastic syndrome caused by parathyroid hormone. It is seen in squamous cell lung cancer. Cushing syndrome. It is due to excess ACTH seen in small cell lung cancer. The third point here is grading versus staging. Grading is the pathologist's job. We answer how ugly do the cells look under the microscope. It is based on differentiation. While staging is the clinician's job, she asks how far has the fire spread in the body. TNM system is the T for tumor size and for regional lymph node involvement and M for distant metastasis. Staging is the single most important predictor of survival and far more important than grading. Dear doctors, in the modern era, the pathologist is no longer just the doctor's doctor. We are the pilots of the oncology team. Without our molecular profile, the oncologist cannot choose the drug and the surgeon cannot choose the scope. Part 9. Lab Diagnosis. The Pathologist's Toolkit. First one in the lab diagnosis techniques are FNAC, the fine needle aspiration cytology. It is quick, cheap, but you lose the architecture of the tissue. Biopsy or histopathology. It is the gold standard for diagnosing any cancer. IHC or immunohistochemistry. We use label antibodies to find the tumor's origin. For example, if the IHC is cytokeratin positive, it points towards carcinoma, whereas vimentin positive points towards sarcoma. Just remember this rule. Next we'll see IHC panel approach. You don't just give one marker, you think in panels. For undifferentiated round blue cell tumor, you look for CD45, for lymphoma CD99, for Ewing sarcoma, Desmin, for rhabdomyosarcoma, and synaptophysin for neuroblastoma. Tumor markers. You check these in the blood. For prostatic cancer, you check PSA. For colon and pancreatic cancer, you check CEA. For liver cancer or yolk sac tumor, you see AFP. For ovarian cancer, you see CA125. And for medullary thyroid cancer, you see calcitonin. Advanced diagnostic pathology. Molecular diagnostics. FISH, fluorescence in situ hybridization. We look for translocations, for example, translocation 1122 in Ewing's sarcoma. Next generation sequencing. It is done to identify targetable mutations like BRAF, EGFR, and ALK. Liquid biopsy. It is used for detecting ctDNA, which is circulating tumor DNA in peripheral blood. This is the future of monitoring minimal residual disease. Now here are Dr. P's exam must-knows. Guardian of genome is P53. Governor of cell cycle is RB gene. Most common pathway of carcinoma spread is lymphatics, and we have seen the exceptions as well. and most common site of hematogenous metastasis is liver and lungs. The Mercedes sign mitosis, it is pathognomic for malignancy. Let's wrap this up. So we have journeyed from the naming of the tumor to the molecular markers that allow it to survive, and finally how we diagnose it in the lab. Remember, pathology is the bridge between basic science and clinical medicine. Master neoplasia and the wards will start making sense. I've created a high-yield PDF cheat sheet of all these tables and flowcharts. The link is in the description. Good luck studying.